Good morning to all, my respected Dean Ma'am, and all the present faculties, and my seniors, and my colleague and juniors. I am Dr. Mayank, second year junior resident, Department of Radiation Oncology, present a student CPC. And for today's topic is that Conundrums of Silent Primary with groaning secondaries. 60-year-old male, Mr. D, he is a resident of Muzaffarnagar, Uttar Pradesh, and he is a farmer by occupation and history given by himself only. He presented with a complaint of swelling over left upper back over the that scapular region, you can see, for last 3 months, and patient has also a pain at local site for around 2 months. History of presenting illness, patient was apparently all right 3 months back when he noticed the swelling over left upper back region. It's insidious in onset only, progressively increases in size gradually to increase to a size of approximately 5 to 5 centimeter. And the swelling was initially painless in beginning, but associated with pain since 2 months only. And that pain is also insidious in onset. It's gradually progressive pain. It's only dull aching in character, mild to moderate in intensity, and the pain is not radiating, and the pain aggravated on movement only of the shoulder region. Patient has no history of any local trauma, no history of left upper limb weakness, no history of neurological deficit, no history of any loss of appetite, loss of weight, no history of any constitutional symptoms, and he has no history of any other swelling in his body except that scapular. Clinical history, past history is not significant. Patient has no similar history in his past, and he has also no known any comorbidities. His family history also remain insignificant. Personal history, patient has a mixed diet. He had adequate sleep with normal appetite, and he has no any addictive habits, smoking or alcohol consumption, and no other environmental or occupational exposure. On clinical examination, patient's echo was 2, and he was conscious, alert, and cooperative with the BMI of 20.14. His all other vitals are within the normal limit, and he has an NRS for pain is 5 by 10. He had no pala, icterus, clubbing, cyanosis, pedal edema, or any peripheral lymphadenopathy. Local examination. On inspection, there was a swelling of size approximate 6 cross 6 centimeter in that scapular region of left side. It's a cranial caudal extension from that spine of the scapula to that lower scapular region, and medial to laterally it's approximately covering whole of the scapular region and till that posterior axillary line. And we can also see that overlying skin area was normal without any stretch marks, no any color changes, no ulceration, no dilated veins, and any kind of discharge. On palpation, there is a no raised local temperature or any tenderness on palpation. It's a bony, hard swelling with immobile, fixed, having smooth surface. The skin over the swelling was pinchable, but there is a restricted shoulder mobility due to pain, and the main restriction is present in the flexion, extension, and the overhead abduction of the shoulder. And patient has no altered sensation and no neurological deficit over the left upper limb. Systemic examination for central nervous system, patient was conscious, having intact higher mental function. He was oriented, cooperative, and there is no focal neurological deficit. In respiratory system, air entry is present equal on the both sides. Bilateral normal vesicular breath sounds heard. And in a cardiovascular system, S1 is 2 present. No murmur. Apex beat is in the fifth intercostal space. Per abdomen is also normal, soft, non-tender, no rigidity, no palpable organomegaly, and also no obvious any kind of spine deformity. So, a summary after clinical history and examination, a summary: a 60-year-old gentleman presented with a history of swelling over left upper back scapula, approximate 6 to 6 centimeter, with dull aching pain only, restricted shoulder mobility for 3 months, without any neurovascular deficit, no skin changes, no constitutional symptoms, and no non-comorbidities.
Thank you, Dr. Mayank.
So he presented in which department?
He first came to that surgery, and after that he came to us.
Surgery first.
Yes, on that.
So these pictures etc. were taken in surgery.
Actually, when he came to us, he also clicked at photographs.
You could have said he was referred from surgery. The directly coming to.
So, simple case for any clinician. So, what could be the differential? So just to add to what Mayank said, initially the swelling was painless, but after a month it became painful, which was gradually increasing in pain. And because of pain, there was and probably scapular involvement, there was this restriction of movement, which was painful. So can we have few differentials of such swelling? Let's forget that case is being presented by oncology or radiation oncology. Anyone? Yeah. Come to the dais, introduce yourself, and give your differentials.
Good morning, everyone. I am Dr. Shrutikant from Department of Radiation Oncology. Probably we can expect a lipoma at that site, but the favors which are against like
Consistency was hard.
yes, ma'am. And it was also a fixed swelling as we checked on palpation. Usually, a lipoma will present with a slip sign. Like there will be pseudo fluctuation, like it can be pressed and it is soft in consistency. So like it can be one differential for that.
Why would lipoma have pain?
Sir, like if the lipoma is big and it is compressing any nerve at that side, then it can lead to pain, sir. Otherwise, usually lipomas are painless, sir.
Any other differential?
Sir, like it can be a bony metastasis from like some unknown primary. There can be a bony metastasis at that site, like scapular mets or something.
How common is that?
Sir, usually,
You are JR, sir.
sir, JR, sir.
How many cases have you seen of such cases in last 2-3 years of primary metastasis to and no constitutional symptoms? You still consider malignancy?
Sir, like I had seen one case which was a like rare case
So,
of carcinoma.
so in medicine, common things are always common. You do not think of first as the rare possibility. What are the common possibilities you will think of? If you get the same case in your exam, what will be your 1, 2, 3, 4 differentials?
Sir, one
First, you said lipoma.
Sir, the second can be, sir, like any abscess, but then in
Okay.
that
Organized abscess, yes.
Okay.
can be abscess, but there were no constitutional symptoms in the patient like fever or like skin changes were not there, erythema was not there.
Okay.
So, and third, sir, like bony mets only.
So now you're fixed towards meds. Okay. Thank you. Any other residents? Come to the dais. Introduce yourself and make comments. So you know the diagnosis better. So don't reveal that diagnosis. If you get such case in exam, what will be your differential?
Good morning to everyone. There can be a possibility that it can be a primary bone tumor.
Okay. So arising from what?
So arising from scapular primary, because there is a bony hard consistently swelling, which is having pain also, which has been an insidious onset of pain. So there can be a probability that it can be a primary bone tumor.
And if you have to guess what kind of bone tumor from scapula,
Sir,
we'll ask the radiation oncologist. Any other differential? So she makes a possibility of primary bone tumor arising from scapula. Yeah. So once you have a localized swelling, you have to think of the structures from which it can arise. It can arise from muscle. It can arise from bone. It can arise from subcutaneous tissue, fat, like lipoma. So people are not coming up with differential. I think you are clouded with the diagnosis. So remember, in medicine, rare cases you are going to see rarely, once in your lifetime kind of cases. But if you get similar case in your clinic, once you are out in practice, what will be the common differential you will think of? Come on. So we have one is lipoma, second is chronic abscess, and third is bone tumor. So yeah, come to a dais and introduce yourself. So your first comment has to be on bone tumor, which bone tumor, and any other differential.
good morning everyone. So bone tumor, this can be osteosarcoma.
You are the expert. You have to tell us. Do you agree that this could be a bone tumor?
But it was not. Yes.
First thing, you agree to this?
It can be bony, as the consistency was hard, and it can be, but it's not that common in scapula, and
So what is that?
yes.
I think we are going towards rarer possibilities. What are the other common possibilities?
It can be a soft tissue tumor also, like soft tissue sarcoma, but that consistency against go against that, but it can be there with and it can be multiple myeloma, with not multiple myeloma, some solitary
Plasmacytoma. Okay. But does this present with such swellings and lumps?
So if soft tissue involvement can be there. Soft tissue involvement can be there. It's not that common again, but it can be there.
So my question to all of you is, what are the common differentials of such a swelling? If you have to enumerate 1, 2, 3, sir, these are 3 common differentials of scapular swelling. What will be that?
Osteomyelitis, then again that no signs of infection.
Okay, thank you. Any other differential? Yes, sir.
I have seen one case of inner side of scapula, about 4 centimeter swelling, and that turned out to be the carbuncle.
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 Okay. Yeah, ma'am.
Why are people not thinking of a rhabdomyosarcoma? Because sometimes it can be firm to hard. Even abdominal leiomyosarcomas are really hard in consistency. So, yes, a bony tumor, of course, but why not a sarcoma? Sarcomas are not always soft. The sarcomas that we encounter in the abdomen are hard.
So the resident made a diagnosis of soft tissue tumor. So possibly rhabdomyosarcoma will come into that. So now,
Even bursitis.
okay.
But site little different.
So we can always have multiple differentials. Ma'am, you can come. So if I have to summarize the differentials, we are talking of lipoma, we are talking of soft tissue sarcoma, we are talking of bone tumor. You said osteosarcoma? Okay. And we are talking of carbuncle, rhabdomyosarcoma, bursitis, and plasmacytoma and METs. So now we have 8 differentials.
Great.
Okay. So, ma'am, if you have to, suppose you are examining resident, and I give you this case in your exam, or hopefully I think you will be getting such cases in your exam. If it's in ward, you will get it.
Yes, sir.
So, what are your first 3 differentials?
Basically, sir, although sir, I am oncology resident, but but the thing is that first.
So, when you get this case, you won't be considered as an oncology resident.
First, we think of sir benign things,
Yeah.
which can be present as this common site on the back, and in old age it could be sir like a lipoma or kind of a cyst or a and so that it's near the joint. It could be sir bursitis, as ma'am rightly said, and it could be also a chronic abscess. So these kind of these should be sir that benign.
And with no comorbidities,
Yes, sir.
no
I think-
constitutional symptoms. You said ECOG of 2.
Yes, sir. Because of that pain, sir, patient is not able to do his activity as that's why, sir.
And does this give us any clue? Initially painless swelling, now after a month becomes a painful swelling. Does it give us some clue?
Uh,
What causes a swelling to be initially painless and then become painful?
Whenever it's going to involve that underlying structures, like the neurovascular structures or any expansion that causes a capsular stretch kind of things, that can lead to sir pain, sir.
So, neurovascular involvement of the surrounding structures and hemorrhage in the cyst. Hemorrhage in that swelling can lead to, because sudden increase in size can lead to, because of hemorrhage there is sudden increase in size that can cause pain. So the faculty of radiation oncology agree with the differentials which we have. Dr. Sweetie, or you want to add something more? So Dr. Sweetie, if your residents give you these differentials, will you pass them?
But as oncology resident, I'll ask them to make a diagnosis of something related to bony tumors or soft tissue sarcoma or a bony metastasis also apart from. But I'll be okay with the differentials what the residents have prepared. But yes, they should not say only the malignant things. They should take the benign things also into their consideration. Should also be there. But I'm okay with all these differentials. Can neurofibroma also be one of the differentials in this patient?
Yeah. So if you talk of metastasis, How common are scapular metastases isolated? Because clinically it appears to be isolated scapular metastasis. So first most common site and how common?
Actually,
How many cases of primary scapular metastasis you have come across in your clinical practice?
if I say only scapular metastasis, I'll say it will be the first or second case we have encountered isolated scapular metastasis in our clinical practice. It is a very rare. Usually, it is in the combination with other findings also, like it will be having bony metastasis somewhere there, or some clue to some primary lesion as well. So it is a very rare to think of a scapular metastasis from or from a primary elsewhere as one of the diagnosis after taking the history and the clinical examination.
Thank you. So, Mang, if you make a diagnosis of a scapular mets, I'll tell you that you know the case. Okay, let's see what differentials you have.
So for after clinical history and examination, with that summary, we have some differential diagnoses. First, it could be that abscess, as it could be tubercular or pyogenic, that slow growing swelling with dull aching pain, and the tuberculous it can present early without any significant systemic sign also. But against points that it's a bony hard swelling without any constitutional symptom, and it's again a non-tendron palpation. Second, it could be a lipoma because it's a mild dull ache, slow growing without any skin changes. But again, that swelling is fixed with very bony hard consistency, and it could be a soft tissue sarcoma as well, with the gradually enlarging mass with dull aching pain, and the patient is also old age in which that sarcomas are common. But again, it's an uncommon site, and it's a bony hard again a consistency which is not seen in soft tissue sarcomas commonly. And it could be fibromatosis, desmoid tumor, with again a slow growing swelling with the lacking pain and gradual progression. But again, it's a old age with a bony hard consistency and having uncommon site. Bursitis could be with the localized swelling, dull aching pain, especially with the shoulder movement, groaning and slowly progressive. But it's a non-tender, no fluctuation, no history of any repetitive movements of trauma, and it's not present over or near the joints. And it could be a primary bone tumor also, with the bony growth present over a bony surface, gradual swelling, painful and bony hard. But against points are it's an uncommon site for osteosarcoma and chondrosarcoma, and again a old age for Ewing sarcoma, which generally present in a young age or a child group of patients. And last, it could be a metastatic disease, metastatic deposit from elsewhere, because it's a gradual swelling over a bony structure with dull persistent pain, but no constitutional symptoms. And primary malignancy used to be identified first. Example, in males, it could be primary from lung or prostate that used to be metastasized to bones. And so also could be a solitary plasmacytoma, multiple myeloma deposit, because again a gradual swelling over a bony in an older age patient with dull persistent pain. But again, non-constitutional symptoms that we see in these plasma cell disorders, and also it's a very uncommon site to be present.
So I'm happy that we were able to pick all these differentials. So let's see how you processed.
So patient have baseline investigations, that hemogram, renal and liver function test. We can see the all are within the normal limits. Viral function, viral markers are also non-reactive. Patient's thyroid function test was also done, which is also in a normal limit. Now I request from Department of Radiology to discuss the radiological images.
Come and join.
Good morning, everyone. I'm Dr. Saransh from Radiology, and I'll be discussing the radiology part. This is a radiograph of the chest, where we can see that there is a ill-defined lytic lesion seen in the left inferior border of the scapula, also extending to involve the medial border. The rest of the lung parenchyma appears unremarkable, and the rest of the visualized soft tissue and bony structures appear unremarkable. These are CT, axial and coronal images of the same patient, where we can see that there is a well-defined pleural-based soft tissue lesion seen in the posterior lateral aspect of the right hemithorax with underlying destruction of the ribs. And we can appreciate the same soft tissue lesion in the coronal images as well. In this image, we can see there's a well-defined lytic lesion involving the left scapula. And in this image, we can see that there's an enlarged lymph node present in the mediastinum in the left upper paratracheal station. And the USG was done.
So what was your differential after CT thorax?
Sir, based on the CT images, my first differential would be metastasis. First differential would be metastasis because this sort of multifocal involvement is less likely to be seen in primary bone tumor. And bone
You haven't shown us multifocal. It's one mass
so
only.
this is one mass, and there is also associated lytic lesion in the opposite scapula.
Opposite scapula.
Yes.
Okay.
So based on these images, we can the first differential will be metastasis. The second differential we can consider as a primary bone tumor because rib involvement is relatively uncommon, but still chondrosarcoma is one of the most common tumors which is seen in the rib zone. But on imaging, there should be presence of calcification or chondroid matrix. The calcification in chondrosarcoma appears as a ring and arc type of calcification, which we are not able to see in this patient.
What about myeloma?
Myeloma is should be considered, but based on the images, based on the age of the patient. But myeloma primarily first most common involvement is of the vertebrae. Ribs and scapula is relatively uncommonly seen in multiple myeloma patients, but still this soft tissue tumor can be a solitary plasmacytoma.
So this doesn't involve scapula. It's primarily the ribs.
This is the rib involvement, sir. But this sort of lytic lesion in the scapula in the upper left side is not commonly seen in myeloma.
So these lesion, the lytic lesion is on the same side as the swelling?
The swelling is on the right side, where the
And that
lytic
doesn't
lesion
have
on
a
the left
lytic
side.
lesion of scapula?
The opposite side.
No, the clinical presentation was swelling on the left side.
Yes.
So what is the left side?
Left side is a simple lytic lesion
Or
on the involving the scapula.
And there's no soft tissue mass.
There is relatively a soft tissue mass in the surrounding area, but these are non-contrast images, and so we cannot appreciate the soft tissue part. The contrast image should be
So
there.
what he showed there is just the lytic lesion and you could not appreciate, and what you're showing us is on the other side.
This is more evident as compared to the scapular lesion. Hence, this I explained it first. This is
You should have explained that first.
6 centimeters swelling.
I'll need a contrast image for this because
But you have a contrast image which you're going to show us.
contrast image in I do not have a contrast image. These are non-contrast images in bone marrow.
You all didn't get a
Ma'am,
contrast
it's
image done.
the CT scan is done outside only, ma'am.
You all didn't get it done here.
No, ma'am, actually.
yeah, carry on.
Later on.
When he presented over, these are the previous outside images which are being outside. Okay.
So you're going to show us the contrast subsequently.
You going to show us?
So we do not have
We have
contrast
that.
images.
You don't have it.
Okay, carry on.
So the first differential would still be bony metastasis. Second differential would be primary bone tumor with contralateral scapular metastasis. And the third differential, based on the age group, we can say that it is solitary plasmacytoma. However, it is unlikely. And in this CT image, there was no presence of any parenchymal metastasis. Hence, soft tissue sarcoma first presents as metastasis to the lung parenchyma and the mediastinum rather than straight away into the bones. Hence, soft tissue sarcoma is a relatively unlikely possibility. Hence, first differential would be bony metastasis based on the image findings.
Carry on.
What about the paratracheal mass you're talking about?
This is a mediastinal lymph node now. In this upper
Quite large
paratracheal, this is a large one.
Thank you. You want to continue? Yeah. You want to tell us the ultrasound findings?
On USG, the thyroid gland was around 2.1 into 2 centimeters with multiple spongiform nodules, and the left lobe was 2.7 to 2 centimeters with a well-defined solid hypoechoic nodule, which was taller than wide and with macrocalcification seen within, extending beyond the common carotid artery. Hence, the lesion was labeled as Tired 5 lesion in the left lobe.
Okay, carry on. So, Mike, why ultrasound neck was? Carry. Why would you get an ultrasound? So, you initially get a CT done in this case, which is metastasis.
Actually, sir.
So, I think the normal protocol would be to get a contrast CT of thorax and abdomen to look for the primary.
Yes, sir. Sure, sir. Actually, sir, that patient came to us with the CT scan report done from outside, which states there is a neck mass. It could be lymph node, it could be thyroid, sir. So it raised the suspicion in us that it could be a thyroid malignancy or something. So just to rule out, because it's a very easy to done and also.
But your clinical examination wise thyroid was
No,
normal.
sir, nothing, sir. In the neck, there is nothing. No swelling is palpable because I also see that the swelling is going posteriorly, sir.
So, how common is metastasis from thyroid without palpable thyroid swelling?
So very rare, sir. But it can be seen in follicular histology.
Why are we going into realms of rare? Everything is rare in this case.
But this will be
What?
routine.
Routine.
So thyroid should be routine in a patient for a workup.
The CT just actually showed a suspicion of the thyroid node.
Okay,
And then if you're looking for primary somewhere else, you have to look at all.
carry on.
After that, we get the USG neck at our institute, which suggestive of Tyrates 5 left lobe of thyroid. In view of that, first we get FNAC, which was done outside review here, which suggestive of only poorly differentiated malignant tumor from scapular swelling. And by side, we also get the USG guided FNAC from thyroid nodule, which was visible on USG. And it was FNAC was negative for any kind of malignancy from thyroid. So till now we show that swelling is a metastatic deposit. So we rule out all the benign things. First, differentials, it could be a metastatic deposit again because of thyroid nodule, Tyrates 5 with the multiple lytic bony lesions. But FNAC again negative. It could be a bone tumor again, but FNAC is negative for any osteoid kind of components which were not seen. And again, it could be soft tissue sarcoma, but again, that my colleague rightly said, in soft tissue, that metastatic bone lesions without lung metastasis is rare. And it could be a multiple myeloma still with the swelling associated of pain, multiple lytic bony lesions. But again, without any pathological fracture, it's again a uncommon site. With no CRAB, we have seen renal function test and hemograms, all are within normal limits. Again, FNAC was negative for any plasma cell deposits.
So, FNAC was done or biopsy was done?
No, FNAC was.
So, any comments from pathologists that?
FNAC was from outside, the slide was
Review.
Okay. And any comments from pathologists? You like to get a FNAC or a biopsy from such lesions? Come to the dice.
Can I say one thing?
Yeah, just after her. After when she makes a comment. Go to the dice. So, question is, if this patient comes to AIMS, okay. Let her answer. Ashok, let her answer. If the patient comes to AIMS and I am the clinician and I send this case to you for FNAC, would you refer it back to me and say, no, sir, get a biopsy done because you'll get a larger tissue, or you're happy to just do FNAC?
So,
Use the dice, use the mic.
So the FNAC will provide a much earlier report. So we can say that whether it is a carcinoma or something benign. So FNAC can be done. Because it will get the report in 2 to 3 days, but biopsy will take time. So I think that
So I'll give you choices. Only FNAC, only biopsy, FNAC and biopsy at one go.
So FNAC and biopsy in one go can be a better option.
Okay, so you choose choice 3. Dr. Ashok, you want to add?
I will prefer FNAC because on FNAC we can differentiate whether it is benign or malignant. After that, we can go for whether we require a biopsy or not.
Okay.
So FNAC should be done. If the swelling palpable, it is not small, we can easily do the FNAC and tell on the same day if it is required.
Okay. Carry on.
So good morning everyone. I will be presenting the histopath part of the case. So we have received the outside slides for the review. We received 4 stain slides, and on lower magnification we can see the cellular smear with the fragments of atypical cells. On higher magnification we can see
These are the atypical cells with high NC ratio and abundant cytoplasm and hyperchromatic nuclei arranged in a cluster and singly scattered. So our impression will be the poorly differentiated malignant tumor. So after this, we received a biopsy from the left scapula with scapular region with a clinical suspicion of thyroid malignancy and left scapular metastatic deposits, ultrasound suggesting of thyroid's 5 nodules. So we received 2 containers, each having the 3 and 1 graphite soft tissue core ranging in length from 0.5 to 2 centimeter. On smaller view, on scanner presentation, we can see that atypical cells are arranged in the papillary forms and with a fibrovascular course. These atypical cells are high. These atypical cells shows high NC ratio, marked nuclear pleomorphism, and clear cytoplasm to the eosinophilic granular cytoplasm. So here also we can see the bizarre anaplastic cells also are there. So the biopsy comprising of papillary and solid areas with abundant eosinophilic to the granular cytoplasm. And so here we can also see that clearing of the cytoplasm is also there. So no nuclear features like nuclear grooving and nuclear clearing or nuclear inclusion was seen here. So biopsy from the scapular region shows the carcinoma. On the basis of histomorphology, we can say, our differential will be the metastasis from kidney, thyroid, stomach, lungs, prostate, and the rare primary clear cell osteosarcoma. For the further categorization, we did the ISC. On PANCK, it is positive, so it is not a osteosarcoma. After this, CA9 is negative. The tumor cells are not taking any stain, so the CA9 negative rule out the mets from the kidney. Then PAX8 was done to rule out the. It is also negative. It ruled out the primary from the colon or peritoneum. After this, Amaker and PSA was done as the patient is a male. So the mets from the prostate is also ruled out. The TTF1, thyroglobulin, BRAF was also done. All the 3s are negative. So primary from lungs and thyroid is also ruled out. After this, CK7 and CK20 is also done. Both are also negative. So the primary from the biliary tract or pancreas is also ruled out. Synoptophysin sulfur is done to rule out any germ cell tumor. After this, synoptophysin also done to rule out any neuroendocrine tumor or any neuroendocrine differentiation. So the diagnosis remains the same, poorly differentiated carcinoma.
Thank you. Dr. Ashok. So everything is negative, Ashok.
Yeah.
So what next as a histopathologist?
So the morphology was of a medium to large size cell with abundant, moderate to abundant cytoplasm, which were eosinophilic granular, and at places it was clear. So clearing of cytoplasm, the most common, if we think of metastasis with those arborizing vessels which are traversing through the tumor, will come to mind is kidney. So, that is renal cell carcinoma, mostly present with this kind of arborizing vasculature, clear cells, which can be also eosinophilic to granular. So my first differential was to rule out kidney. When I ruled out that, second, there was a history that there is a thyroid 5 nodule, so I went for the markers of thyroid. So those were also negative. After that, it became a guessing game. So because bony mets is there, we can think of a papillary tumor arising rarely from prostate. So we went for prostate. Then CK7 and 20, because this patient's initial complaint was of bleeding PR, with which the form was sent to us. So I also try to rule out a tumor from colon, CK7 and 20.
No mention of bleeding PR was.
I have that. Yeah, from surgery the form came with a history of
So, but how does history change from surgery to radiation?
complaints of bleeding
It's
per
always
rectum,
the
swelling
same.
of the left scapula. So that's why I also ruled out that any meds from colon. So after that, osteosarcoma rarely can have large cells which will be showing clearing of cytoplasm, but that's extremely rare, and even in scapula that will be very rare.
Thank you.
But that with no osteoid, it's very difficult to say that.
Okay. Yeah.
Thank you.
Quick comment. And Mayank, you need to clarify to the audience about this bleeding PR thing.
I think they're going to talk about it, but before the slides went for histomorphology, there should have been a complete metastatic workup done, and then the pathologist should have been told that we've done a complete metastatic workup. And there is nothing from any other side, because he is looking for kidney and not blindly. He doesn't know what is there in the kidney or in the other parts, because you'll have not mentioned the metastatic workup here. I'm sure you will come out to it later. But I think as the flow of things go, when it goes to a pathologist, when you're not thinking of a primary metastasis, a metastatic workup should have been done before it went to the pathologist.
Yeah, I agree to your point. I think we're short of time.
Again, I request my pathology colleague to please comment on that.
So initially it was FNAC, now you've got a biopsy.
Yes, sir.
It was still a thyroid side.
So we received a tissue biopsy from the thyroid nodule. On the scanner view, it is showing the thyroid follicular cells arranged in a follicular pattern. So this is a normal histology of the thyroids with the normal thyroid follicular cells, and the colloids is there. So no evidence of any malignant cell is seen here.
So no malignancy in thyroid.
Yes, sir, no malignancy in thyroid.
Okay. So we can now conclusively say there is no thyroid malignancy. This thyroid 5 was a red herring. Okay. Nuclear medicine.
Good morning again to all the professors.
So this was done as part of metastatic workup. Just to clarify to the audience, you have a patient who has a poorly differentiated malignancy from a scapular lesion, and pathologist is not able to tell us from which organ it has risen. So as part of a metastatic workup, you have got a PET CT done. That's it? Okay.
So after all this, the initial FDG PET maximum intensity projection image showed the physiological tracer uptake involving the brain and the urinary bladder, followed by multiple sites of abnormal FDG uptake in the thorax, abdominal, as well as in the pelvic regions. So craniobodily as going, the initial reconstructed fused PET CT as well as the CT image showed there is a well-defined hypodense lesion in the left lobe of thyroid posteriorly with few internal foci of calcification, with no significant FDG uptake with ICU of 1.8. So it might be likely benign. Then, when in the thorax section, we got multiple FDG uptake, FDG avid, bilateral hilar and paraesophageal lymph nodes, followed by which the abdominal section shows a ill-defined hypodense lesion in the segment 5 or 6 of the liver with intensely FDG avid with an SU of 5.5 and a conglomerated mass, likely lymph node, in the periportal region. So this section again shows a conglomerated mass of lymph nodes in the paracaval, aorta caval and retroperitoneal lobe. So the same coronal section is reflecting the FDG avid hypodense lesion in the liver and the conglomerated mass of lymph nodes in the retroperitoneal region. The same sagittal section reflecting the hypodense lesion in the liver, which is of segment 6. When we talk about the bony lesions, there was an intensely FDG avid scapular lesion in the left scapular inferior border, which is a lytic lesion and with soft tissue component. As well as there were similar multiple lytic lesions with soft tissue components noted involving the cervicothoracolumbar sacral vertebra, and this lesion showing this arrow showing the right 6th rib. As well as there were certain lesions in the right 8th rib as well as in the L3 vertebra. There are few other vertebrae, C6, C7. And then The right iliac bone is also showing a lytic expansor with soft tissue component lesion as well as in the right acetabulum. So it can be a multiple metabolically active mediastinal retroperitoneal lymph nodes with metabolically active solitary lesion in the liver and multiple skeletal lesions. So it could be a first differential can be considered as metastatic from unknown primary. But however, there is one more differential to be considered in view of a metabolically active hypodense lesion in the liver. So liver primary should also be considered as one differential as it is having multiple mediastinal abdominal lymph node with multiple lytic skeratalis. Therefore, finally the patient was advised for biochemical, histopathological and high-risk correlation against the lesion.
So, why liver primary?
So because
This looks more like a mets. You have lesion in the liver, you have portal lymph nodes, you have multiple skeletal lesions, multiple mediastinal lymph nodes. So why liver primary?
so because of the ill-defined hypotenuse lesion, which is also FPG event. That could be a main thing, and the liver metastasis will also have patterns like lytic lesion with soft tissue component in the vertebra, like bones or skeletal bits.
So what was the reported? Was this reported as liver primary?
So liver lesion was also commented and suggested for biopsy and IHC correlation.
Okay, yeah. We come to the diastemic. Thank you.
So why are you not considering the liver lesion also as secondary? Why do you consider it as primary?
Mom, that's why we have made two differential. One is metastasis from the unknown primary with a probability that liver lesion can also be a metastasis. And there is again a probability that ruling out the thyroid and provided that the biopsy from the thyroid is also negative, the liver lesion can also be a primary with a metastatic lymph nodes and.
So how will you differentiate a metastasis to liver, solitary mets to liver with a primary HCC or nuclear medicine imaging?
So it will be a bit difficult only with the SUV.
So you have the SUV in this case.
Yes, sir.
So what was that showing suggestive of?
So SUV of the prime, like liver was 5.5 and the SUV of scapular lesion was 11.8 and lymph node was also around 7.8. So there can be a possibility.
You're not giving us a clear answer.
Yes, sir. Like
You have given us three different SUV values and I don't know what you're trying to say.
no, sir. My point is, we should consider in a setting of all these ruled out situation, we should consider this liver lesion as also a primary thing.
So the primary lesions SUV is less and the metastatic SUV is more.
So there can be a possibility like that.
Okay, yeah. Thank you.
Good morning, everyone. Based on the SUV, we cannot decide which is the primary. Generally, primary has high SUV, but it is not like that. Metastatic lesion from the primary can have more SUV. Is based on the type presence of cell and metabolism. If a metastasis lesion has more cell than the primary, obviously it can have more SUV than the primary. It is not like that. Always primary will have high SUV.
So my question to you, Dr. Vivek, is this patient normally HCCs develop in the setting of cirrhosis.
Yes, sir. Exactly, sir.
Okay. So this patient doesn't have any features of chronic liver disease. He's not cirrhotic. His LFTs are absolutely normal. His viral markers are negative. We know hepatitis B can have HCC without developing cirrhosis. Viral markers are negative. And still keeping it as a primary from liver will be...
Sir, our first differential was metastasis to the mediastinal node, abdominal node and liver lesion, and multiple lytic lesion was given as a metastatic lesion from a non-primary because any other organ was not involved in this particular patient. Only visceral lesion was present in the liver. So second differential we gave that liver can be the primary site because advanced disease of gastrointestinal tumor, any genitourinary tumor, any lung primary can present metastasis to the everywhere, which is we are looking in this particular case.
Thank you. So did we have a CECT abdomen in this case? Yeah, ma'am. A triple phase CT showing characteristic Lyrite 5 lesion.
Actually, answering to the ma'am's question also, we advised all the investigations to the patient when the patient presented to us. But because of the financial and logistic issues, in whichever order the patient got the investigations, we have presented it here. Because we were also because we were dealing with something different for the patient and the reports was little bit confusing. Like ultrasound neck was something confusing which shows that it's in the line of the thyroid. We advised a PET CT because we did not do a CT abdomen investigation because we found that we are dealing with something unusual. So we straight away advised a whole body PET CT along with the rest of the investigations to the patient. But once the PET CT was done, we did not advise further triple phase CT to this patient because still it was like a metastasis from the liver and liver primary was not a very commonly for this as a differential diagnosis for us also for this patient.
Thank you. Quickly, ma'am. We have 12 minutes left.
Sure, sir. So, after getting this PET CT scan and advice as a biochemical and histopathological correlation, so we asked the patient to get all the pan tumor markers. We can see here that PSA, CEA, CA19.9, HCG, and LDH all are within the normal limit except that AFP. Alpha fetoprotein is a highly raised, it's a more than 7,000 of nanogram per ml. And after that, we asked the pathologist, our colleague, to get apply IHC in the line of AFP, and we have two differentials. Then it could be a metastatic hepatocellular carcinoma with raised FEP, only a FDG with lesion in liver with ioto and cable lymphadenopathy. But again, it's a very single lesion, less than 3 centimeter kind of nodule with a normal LFT, no risk feature, non-alcoholic, no viral marker, no cirrhosis, and it could be a germ cell tumor also. But patient has a normal testis and no retroperitoneal as such big mass or mediastinal, and a patient is a old age also, in which it's a very unusual to get a germ cell tumor, sir.
Okay. So quickly, histopathology. So suddenly the diagnosis has changed from metastasis to HCC.
Yes,
So
sir.
AFP is a quite sensitive marker for hepatocellular carcinoma, and it's pretty high, more than 7,000 nanogram per ml.
So we did the glypican 3, so tumor cells are showing the positivity. And after this, we did the arginase 1. So on the basis of glypican 3 and arginase 1, our diagnosis will be the metastasis for hepatocellular carcinoma. So because arginase will differentiate between the hepatocytes mets.
So papillary variant of hepatocellular carcinoma.
So this is actually there are 4 types of patterns of SCCs are seen: trabecular, pseudotrabecular, solid, and macrotrabecular. Rarely a papillary pattern is seen, one of the few case report which was presented with the hepatocellular carcinoma with an unusual papillary vascular appearance is there. But in this report they have mentioned it that the papillary pattern is basically trabecular pattern has been distended, and because of that also they can show a papillary variant.
So next time you get similar case, will you do glypican and arginase?
So if the history is provided and if we have something in related to the history, then we can also do a IC marker for liver also.
Because it's going to add to the cost of investigations. You can do 1,000 tumor markers.
But sir, whatever the history is provided, we can go according to that line also. And since that case has been presented, so I think that we can also apply one more marker for that to rule out that lineage also.
So if you have to choose between glypican 3 and arginase, which one you will choose?
So I will choose arginase 1.
Okay, thank you. Dr. Ashok, you want to make a comment? You can take your seat.
Generally, hepatocellular carcinomas, whenever they present with METs, they are well differentiated. So they will be large polygonal cells with abundant granulocytoplasm and vesicular nuclei, which can be binucleotide types. That gives a basic clue that this could be from hepatocellular origin. But in this tumor, the morphology, it was like a kidney tumor, clear cell renal cell carcinoma. There were no binucleation, nuclei was hyperchromatic. So we never thought of that this could be a presentation from a hepatocellular carcinoma. I have seen METs from hepatocellular carcinoma to ribs, presenting as occult METs, and sternum, but there also the cells were large, polygonal, and they were looking like hepatocytes. But if the differentiation becomes less, it becomes difficult. But I think this is also a message to us also that when we see clear cells, granular cytoplasm, apart from all, we should also think of a hepatic plan and add one marker. And for markers, arginine 1 is a very specific marker for liver because it is involved in the urea cycle. So if it is positive, that means this tissue, wherever it is coming from liver.
Okay.
That is for sure.
But then it opens another Pandora's box of what was the underlying etiology in the liver to cause HCC. So this patient has viral markers which are negative. So can you mention viral markers is negative. So for residents, two situations where HCC can develop without underlying cirrhosis is chronic hepatitis B. And now we are seeing a lot of cases of MASLD, earlier called as NAFLD, where you can have HCC without developing underlying cirrhosis. So his HbS-Ag is negative, but I would definitely go for total core and HBV DNA in this case. And what was his maximum body weight in his lifetime would be important. He doesn't have diabetes, and if the surrounding liver on imaging was showing fatty liver, then that will give us some clue that this patient may have underlying fatty liver disease, which has subsequently led to development of HCC.
So, the patient built is only average, he's around 60 kg of weight, and we can also see there is no fatty liver or anything down, but still it's a very infrequent that we can see the HCC without any kind of underlying risk factors. So for metastatic hepatocellular carcinoma, we have given a palliative radiotherapy to left shoulder to relieve his pain, and to also that impending fracture in the vertebrae of cervical and lumbar. And finally, patient was started on targeted therapy, sorafenib, in mid of June. So at last, the discussion, HCC is the most prevalent primary of the liver. It's known to arise in the setting of CLD, chronic liver disease basically. But incidence of presenting with extrahepatic spread at time of diagnosis is 5 to 15%, and metastasis to bone is also reported in around 15% in metastatic HCC patient. And HCC bony mets manifest as a large soft tissue masses which causing bone damage. And
Just hold it here. Okay. So any comments from faculty? Director ma'am, you have any comments? Ma'am, are you online? Okay.
Hello.
Yeah, ma'am.
I'm online. Thank you very much, Rohit, for ultimately turned out to be your specialty.
Well, I'm still not very convinced. Still not very convinced.
But do you think this is the type of CA liver which will come after NAFLD? Because this patient, do you think he would have had although he was pretty old,
Ma'am, your question was not very audible.
would it be hepatic carcinoma following NAFLD?
Yeah, it could be NAFLD because 20% of Asian NAFLD are normal weight, so their BMI is normal. So maybe, but the odd point is he doesn't have any other metabolic risk factor. He's not diabetic. So I would look for occult hepatitis B in this case, total anti-HBC, HBV DNA, because we know that HbS-Ag can be still negative around 5% of these patients. So still work up for
80 years, no? 80 years of
60.
60. Okay. Okay.
Yeah.
Okay, it was very, very well discussed. Thank you. Thank you very much.
Yeah, Dr. Shalini for the.
You don't think of any genetic causes for hepatocellular carcinoma? There are no genetic causes at all? Because hepatobiliary and all could have genetic causes. Why are we going only with NAFLD and hepatitis and other causes of hepatocellular? What percentage of hepatocellular carcinomas have a genetic origin?
Very nice.
So Ben, you need to answer this. You're the presenter, you need to answer this.
Actually, sir, in this patient, we didn't get any kind of genetic testing,
What
sir.
is it? You didn't get it as a different thing, but what is the percentage of genetics
Uh,
causing hepatocellular carcinoma? Because in every cancer, you have 5% of a genetic cause.
Sorry, ma'am, actually, I don't know exactly about that, what could be for genetic percentage in because
In hepatocellular.
just,
Hepatobiliary?
I mean, it's hepatobiliary is there, ma'am.
Actually, patient.
Yeah, Dr. Sweetie, for your last comments.
Knowledge.
Just we agree, ma'am, when we are not getting to any etiology. But one thing is that, yes, Dr. Arwati, as you said, HBV RNA titer you said,
DNA.
DNA. One thing we will definitely get patient is in follow-up with us also and receiving treatment. Second thing is that, ma'am, yes, if we want to go for patient requires a NGS to looking for some mutations and association which might be having a genetic factors associated with hepatocellular carcinoma. Only thing is that the cost added to it. The cost.
10,000, 13,000 NGS.
But when hepatocellular will require a bigger panel for that, a small limited
The whole
panel.
genomic sequencing has become very cheap now.
So that will, because he is a non-beneficiary, getting treatment done for him is also a little bit problematic for us. Second thing is, whatever treatment we have started, he has responded very well, and at present his biochemical response, AFP has gone down to 1000. So he is responding after 3 months of treatment. He had oligoprogression at some of the sites in bony lesions, which we have given radiation also. And definitely this part we can get it done. We will discuss for the NGS for this patient definitely, because it's an interesting case and we should look for the genetic causes. We are not able to get the etiology for the patient. And just there are only 3 cases reported in as far as we have studied the literature for presenting as a scapular metastasis in the world, and ours is the 4th one with the highest AFP levels among all the 4 cases which have been reported in the literature.
Thank you.
Thank you.
So we have a very interesting case of a 60-year-old male with scapular mets with primary arising from liver. Thank you, Department of Radiation Oncology, and thank you for all the participants for active discussion. Thank you.
So you've been quite inspiring for the people in Bhatinda, and I have professors of pathology sitting here with me. And they've gone through your CPC. Thank you very much.
Thank you, ma'am. Thank you for all the active participation.
Okay, thank you.